Mabuhay and welcome to East Derma Airlines. Ladies and gentlemen, we will be taking off shortly, so please straighten up your seat back. Make sure your seatbelt is securely fastened, window shades fully opened, tray tables towed, and get ready because we will embark on our journey in a few minutes. Maraming salamat po.
Passengers for flight GA, please go to gate 26.
Mabuhay and welcome to East Derma Airlines. Ladies and gentlemen, we will be taking off shortly, so please straighten up your seat back. Make sure your seatbelt is securely fastened, window shades fully opened, tray tables towed, and get ready because we will embark on our journey in a few minutes. Maraming salamat po. Compliance ng mga pasyente.
Hindi ako nakikita dyan, ha?
Passengers for flight GA, please go to gate 26.
Mabuhay and welcome to East Derma Airlines. Ladies and gentlemen, we will be taking off shortly, so please straighten up your seat back. Make sure your seatbelt is securely fastened, window shades fully opened, tray tables towed, and get ready because we will embark on our journey in a few minutes. Maraming salamat po.
Passengers for flight GA, please go to gate 26.
Mabuhay and welcome to East Derma Airlines. Ladies and gentlemen, we will be taking off shortly, so please straighten up your seat back. Make sure your seatbelt is securely fastened, window shades fully opened, tray tables towed, and get ready because we will embark on our journey in a few minutes. Maraming salamat po.
Good afternoon, everyone. Today is the second part of this very special pediatric dermatology lecture series. And to start this afternoon's conference, I would like to go over our Zoom etiquette. Kindly mute your microphone when not speaking to minimize interference. And if the meeting gets cut off, just log in again. You may type your questions on the chat box during the question and answer portion, and I'll go over it and ask it to our presenters. Now, to start off today's conference, may I now call on Dr. Riza Ossie.
Let us begin with a prayer. Lord, help us listen with open minds and hearts as we begin our pediatric case lecture series today. Guide us, Lord, to learn more about our specialty, dermatology, and to build our knowledge for the sake of our patients. Amen.
Okay, Riza, before you start on your case discussion, let's start off with a poll question. So if you see this lesion in a pediatric patient and it comes into your clinic, what sort of course of action will you do? Number one, you'll just say, oh, this looks benign. Let's leave it as is. It should resolve on its own. Or you will say, oh, I'll try to ultrasound this. Or letter C, oh, I will refer to a pediatric dermatologist or the plastic surgeon. Or, of course, I want to excise this one. So I'll give you 5 seconds to put on your poll. 5, 4, 3, 2, 1. We close the polls now. Can I see the response? Okay, so there's kind of a split answer between I will refer it and I will ultrasound it. So I think, Riza, it's time for you to help us know what should we do in this type of cases. Thank you.
Okay. Thank you, Dr. Walensunden. Good afternoon, doctors. Let's wander in the peculiarities of vascular malformations in our pediatric dermatology lecture series. I am Riza Mayem Ossie, a first-year resident from East Avenue Medical Center, and I'll be presenting the not-so-little prince with Verrucous Hemangioma. Will genetic testing lead him home? Part 1 would be a case discussion of Verrucous Hemangioma, and Part 2 would involve conversations with experts in the field. I am very grateful for my advisor and moderator, Dr. Wilsie Salens Walensunden, for her guidance, Dr. Siripun Varapon for her guidance in dermoscopy, Dr. Eva Cotionco de la Paz, and Dr. Gisela Umali Adasa for sharing their field expertise at the latter part of the conference. Also, my senior for this case, Dr. Alas, for assisting me throughout the case presentation process. And of course, I would like to thank Dr. Lavadia, our chairman, and Dr. Prieto, our training officer, for the chance to present this case for this conference. So, let's travel the world of vascular malformations. The objectives of this conference is flashed on your screen. Now, let's begin with our case. Our patient is DA, a 10-year-old male from Quezon City, who came in with a chief complaint of nodules on the right leg. For the history of present illness, at birth, patient was noted to have a solitary, dark, violaceous papule on his right leg, approximately 0.5 by 0.5 centimeter in size. No other significant skin or mucosa lesions were noted. During the interim, the lesion progressively grew in size to a nodule, as with the patient with a new satellite lesion on the same area. This is associated with occasional pruritus, pain, or bleeding after exposure to trauma or scratching. Also, the lesions were noted to have occasional scaling on the surface. No joint pains, tenderness, limitation in the range of motion, edema, and relative limb size discrepancy noted. No consult was done, nor medications were applied or taken. Persistence of lesions prompted consult at East Avenue Medical Center Dermatology for evaluation and management and consultation with our pediatric dermatologist. For our review of systems, it is generally unremarkable. The past medical history is non-contributory. For the family history, his father passed away last March 2021 acutely with an unrecalled heart disease and kidney disease. The mother had a previous PTV infection 10 years ago and has already completed 6 months of treatment and cleared of the infection. No other diseases in the family noted. For the fetal-maternal history, patient is born to a 38-year-old G6P6 6015 full term via normal spontaneous delivery without complications in a lying-in center in Quezon City. Patient's mother denied any exposure to teratogens, radiation, and other toxic materials during the course of the pregnancy. No other maternal illnesses were noted during the course of the pregnancy. For the feeding and immunization history, Patient was breastfed for 5 months and discontinued due to PTB infection of the mother. Patient was then switched to formula milk, and then complementary feeding was started at 7 months of age, composed of rice and vegetables mixed with powdered milk. Mother claims that the patient completed immunization from local health center up until 9 months of age, but mother does not recall which ones were given. Mother claims patient's developmental milestones are at par with age. For the personal and social history, the patient is the youngest among 5 siblings. He lives with his mother in a clean, poorly lit, properly ventilated, single-story house as claimed by the mother. No exposure to smoke, pollution, or toxic chemicals are noted. His drinking water is sterilized and garbage is collected twice a week at home. For the lifestyle history, sample diet is flashed on your screens. His diet mostly includes fried food and processed food. Fluid intake is mostly of water and milk. Activities include playing street games with neighbors and friends and wears pants most of the time when going out due to his lesions on his right leg. He is currently a grade 6 student and attends module learning at home due to the pandemic, but is still one of the top students in his class. Sleep pattern is unremarkable, and patient does not have any other physical activities such as exercise or sports currently. Children Dermatology Life Quality Index was assessed in our patient. Scores resulted to a grade of 11, which means the patient's disease has moderate effect on the patient's life. The patient's mother disclosed that the patient gets teased by his classmates and friends all the time and prefers to wear pants just to hide his lesions. The physical examination is non-contributory with normal and unremarkable findings. The BMI of the patient is 14.8, which according to the WHO growth charts, BMI for age graph is normal for age 10. For the rest of the PE findings, let's focus on the extremities. The patient has full and equal pulses, no cyanosis, no edema, no limitation of motion, no relative limb size discrepancy, and no palpable lymphadenopathy. For our cutaneous findings, patient was noted to have few, well-defined, multilobulated, rubbery, non-pulsating, non-blanching, non-compressible, violaceous nodules measuring 5 by 4 centimeters and 1.5 by 1 centimeters on the right leg. No warmth or areas of erythema noted, and no leg diameter discrepancy noted. Dermoscopy revealed dark blue to black lacunae with surface scales. The yellow circles showed red to violaceous dots and globules. The blue arrow points to surface scales. And again on this slide, blue circles represent red to violaceous dots, and the yellow circles represent red to violaceous globules. For our salient features, our patient is a 10-year-old male. The lesion is present at birth and is a violaceous papule on his right leg, which progressively grew in size to a nodule as with the patient. This is associated with occasional pruritus, pain on pressure, and bleeding after exposure to trauma or scratching and scaling on the surface. No joint pain, tenderness, limitation in the range of motion, edema, and relative limb size discrepancy noted. For the objective findings, patient is noted to have few, well-defined, multilobulated, rubbery, non-pulsating, non-blanching, non-compressible, violaceous nodules measuring 5 by 4 centimeters and 1.5 by 1 centimeters on the right leg. Dermoscopy findings reveal dark blue to black lacunae with surface scales and red to violaceous dots and globules and surface scales. For the primary working impression of the patient, we are considering a vascular malformation, lymphatic malformation versus verrucous venous hemangioma or verrucous venous malformation to rule out congenital hemangioma, probably non-involuting type, and angiokeratoma circumscriptum. For my differential diagnosis, my primary working impression for this case is verrucous hemangioma or verrucous venous malformation. This is a rare disease and noted at birth. Lesion spontaneously never involutes. Patient presents with violaceous verrucous nodules, commonly on the lower extremities, but may appear anywhere. Lesions are asymptomatic but can be painful in response to trauma. All of these are included in the patient's characteristics, hence, I have no reason to rule this out. Lymphangioma circumscriptum is another consideration for this case. This appears at birth but may occur at any age with a predilection site commonly on the extremities. However, lymphangioma circumscriptum usually presents as translucent cutaneous vesicles resembling frog spawn appearance. This usually presents with a myriad of colors ranging from clear, pink, red, purple, or black. Hence, the diagnosis is less likely, but I cannot entirely rule this out. Infantile hemangiomas is a possible differential. Infantile hemangiomas are the most common benign tumors of the childhood. Infantile hemangiomas usually is absent at birth or with the presence of an nascent infantile hemangioma. Non-involuting type usually occurs in the trunk and lower extremities. However, the lesion is less likely because patients present with a less progressive course compared to our patients. And finally, angiokeratoma circumscriptum may also be considered. The lesion is usually noted at birth but may develop in childhood. The lesions are commonly found at the lower extremities and is similar to the patient as it is asymptomatic, but can be painful in response to trauma. However, the lesion is less likely as the morphology of angiokeratoma are macules evolving to papules coalescing to plaques.
Okay, before you proceed on to the course at the OPD, does anyone have any question for our presenter? Riza, how about
Yes.
lymphatic malformation? How will you rule out lymphatic malformation in this case?
So for lymphatic malformations, Doctora, it is another consideration for our case. We are ruling it out usually, Doctora, because they present as translucent cutaneous vesicles resembling frog spawn appearance. This usually presents with a myriad of colors ranging from clear, pink, red, purple, or black. Hence, the diagnosis is less likely.
Correct.
Doctora.
And most of the time, if it's a lymphatic malformation, you would notice that there's fluid buildup within the lesion. All right.
Yes.
So are there any questions? Okay.
Riza.
Hi po, Doctora.
Yeah, I think you forgot to mention in your clinical description the surface, to describe the surface of the lesion.
Okay, yes po, Doctora. So for my lesion po, Doctora, some parts are smooth po, Doctora. But there are parts po, Doc, that are scaly and hyperkeratotic po, Doc.
Okay, scaly and hyperkeratotic. Okay.
Yes po, Doctora.
Okay, thank you.
Thank you, Doctora, for pointing that out. Okay, you can continue your course in the ward.
Before we begin with our course in the ward, here is a summary of the course in the OPD. So during the initial consult in the OPD, we requested for skin punch biopsy of the right leg and basic laboratory tests with additional laboratory for the contemplated medical and surgical treatment. We also requested for imaging, which includes chest x-ray, bilateral knee APL, and MRI study for the right knee to support our diagnosis. Therapeutic-wise, we prescribed cetirizine to give 10 ml as needed for the pruritus. For the topical mupirocin ointment twice a day on the post-biopsy site for 7 days, the expansionol and glycerin cream to apply twice a day as needed for the pruritus. We also advise the patient to use mild soap and emollients and to avoid trauma and scratching of the area. CBC results showed neutropenia, eosinophilia, and thrombocytosis, while the rest of the lab results are within normal limits. For imaging studies, it is important to note that the chest x-ray is unremarkable. For the bilateral knee x-ray, there is note of no bony involvement on the right leg and soft tissue mass density seen in the medial aspect of the proximal third of the right leg. For the MRI study of the right knee in multiplanar view, we want to emphasize that there is demonstrated communication with the greater saphenous vein. The radiologist signed out the MRI with an impression of primary consideration of vascular malformation, probably venous. For the histopathology report, I would like to introduce my senior for this case, Dr. Tanya Alas, to discuss the histopathology report of our patient.
Good afternoon, doctors. Let me just share my slide. Can you see my slides po? Can you see my slide? Right?
Yes,
Yes po, Dr.
yes, Tanya.
Thank you po. So good day, doctors. I will be discussing the histopathologic findings of this case, and I would like to thank my advisor, Dr. Francesca Quino, for her guidance. So before we proceed with the patient slide, let me first discuss a few terms relevant to this case. So here's the histology of the normal skin. It is divided into several layers. The epidermal layer, composed primarily of keratinocytes, separated from the epidermis by a basement membrane, is the dermis, divided into the papillary and reticular dermis. And below the dermis is the subcutis, which is an underlying cushion formed by cells engorged with lipid and nourished by vessels that grow within a thin intervening septae. So let us now shift our focus to the dermal microvascular unit. So this is, on the left, is a scanning view of the skin, and the dermal microvasculature is divided into two important strata. The first, the superficial vascular plexus, defines the boundary between the papillary and the reticular dermis and extends within an adventitial mantle to envelope adnexal structures. And this plexus forms a layer of anastomosing arterioles and venules in close approximation to the overlying epidermis. And small capillary loops emanate from the superficial vascular plexus and extend into each dermal papilla. And the second plexus is the deep vascular plexus, connected to the first by vertically oriented reticular dermal vessels and separates the reticular dermis from the subcutaneous fat. And many of these vessels are larger in caliber and communicate with branches that extend within fibrous septae that separate lobules in the underlying subcutis. So let me discuss the different vessels that we may find in the dermis. First, dermal lymphatics. These are often inconspicuous in normal skin because they do not have a well-developed wall, as is the case with blood vessels. But they are easily detected, however, when they become slightly ectatic as a result of increased lymphatic drainage. And lymph vessels, as you can see, are not rounded in contour, but instead show angulations dictated by the fact that their linings are buttressed by adjacent collagen bundles. Next is the capillaries, and these are present throughout the dermis, but especially in the papillary dermis, composed of a layer of endothelial cells surrounded by an incomplete layer of pericytes. A basement membrane, which stains positive with PAS, is present peripheral to the endothelial cells and surrounds the pericytes. And then the small arteries of the deep vascular plexus and the arterioles of the dermis possess three layers. The intima, composed of a thin endothelial cells and an internal elastic lamina that stains for elastic tissue, a media which contains two or more layers of muscle cells in small arteries, but only a single layer in the arterioles of the lower dermis, and a discontinuous layer of muscle cells in arterioles of the upper dermis. And finally, the adventitia of connective tissue. And then the walls of the veins are generally thinner than those of arteries and are less clearly divided into three classic layers. And the postcapillary venules resemble capillaries because they consist of endothelial cells, pericytes, and a basement membrane. So moving on to the case, our patient is a 10-year-old male presented with a history of a dark biliaceous papule on his right leg since birth, progressively enlarging to a nodule associated with bleeding with trauma. So we did a 4mm skin punch biopsy on the lesion. So this is the patient's slide on scanning view. And on closer look, the section shows basket weave orthokeratosis, acanthosis, and cerasiform epidermal hyperplasia, and dilated lymphatic channels containing eosinophilic proteinaceous material in the papillary dermis. There are also densely aggregated thin-walled vessels and thick-walled vessels in the deeper dermis that display abrupt changes in thickness on the medial and elastic layers, and these vessels are separated by fibrous tissue. And few siderophages are also seen in the dermis. So here is a summary of the salient histopathologic features: basket weave orthokeratosis, acanthosis, psoriasiform epidermal hyperplasia, dilated lymphatic channels with eosinophilic proteinaceous material in the superficial dermis, thin-walled and thick-walled blood vessels in the mid to deep dermis separated by fibrous tissue, and a few siderophages. So for my histopathologic differential diagnosis, I will be dividing my discussion into two: the findings seen in the superficial dermis, and the findings in the deep reticular dermis. So for the dilated vascular spaces in the superficial dermis, my first differential is lymphangioma circumscriptum. It is predominantly a developmental malformation of infancy but may arise at any age, and the typical lesion consists of collection of numerous papules and vesicle-like lesions containing clear fluid and less commonly blood. So lymphangioma circumscriptum, lymphangioma circumscriptum shows acanthotic epidermis, some degree of hyperkeratosis, thin-walled lymphatic channels usually present in the superficial dermis, usually containing clear to proteinaceous fluid, and less frequently red blood cells in their lumina. And these findings are similar to what we have seen in our patient. Next is angiokeratoma circumscriptum. So there are 5 types of angiokeratoma, and these represent true ectasias of blood vessels of the superficial dermis. And the least common type, the angiokeratoma circumscriptum, but a close differential to our case, is this, and it presents as linear multiple dark brown hyperkeratotic papules with irregular borders on the lower extremities which bleed on trivial trauma. Histopathologic examination of the skin lesion in a patient with angiokeratoma would present with numerous dilated or ectatic thin-walled vascular spaces in the superficial dermis and acanthosis with elongated rete ridges similar to that of our patient. However, in angiokeratoma, congested capillaries can be seen and thrombi is common, hence this is less likely. Hobnail hemangioma is a relatively uncommon vascular tumor that usually presents in the trunk or extremities of young or middle-aged adults with male predominance. And the typical clinical appearance is characterized by a small solitary lesion consisting of a brown to violaceous papule surrounded by a thin, pale area and a peripheral ecchymotic ring. So microscopically, this would present with dilated or ectatic vascular spaces in the superficial dermis and hemosiderin or siderophages similar to that of our patient. However, these vascular spaces are often lined by bland endothelial cells with scanty cytoplasm and rounded nuclei that protrude into the lumina, closely resembling hobnails, and this was not appreciated in our patient. So out of these, we can say that the most compatible with our patient is lymphangioma. For the next part, for the dilated vascular spaces in the deep dermis, our first is arteriovenous or cirrhoid hemangioma. Usually occurs as a solitary dark red papule or nodule on the face, especially the lip, or less commonly on extremities of adults with equal gender incidence. So like cirrhoid hemangioma, our patient presented with thick-walled and thin-walled vessels lined by a single layer of endothelial cells in the dermis. The walls of the thick-walled vessels consist mainly of fibrous tissue, but in most instances also contain some smooth muscle. In cirrhoid hemangioma, the internal elastic lamina is found in very few vessels, indicating that most are veins, just like in our patient. Next is verrucous hemangioma, and it presents as a warty dark blue nodule mainly on the extremities, especially lower limbs of children. It is a rare form of vascular malformation that is usually congenital and only rarely presents later in life. So histologically, the superficial portion of verrucous hemangioma is indistinguishable from angiokeratoma as previously discussed, with dilated vessels in the superficial dermis and acanthosis. However, a combination of congested capillaries and cavernous-like vascular spaces is seen extending into the deep dermis and subcutaneous tissue. And what makes this a less likely diagnosis is the absence of hyperkeratosis, papillomatosis, and thick-walled vessels in our patient. And lastly is cavernous hemangioma, typically seen at birth. It may affect the skin, subcutaneous, or visceral organ, and it demonstrates soft, compressible, bluish-purple tumor or plaque, which swells with exertion on dependent position. So histologically, these are composed of irregular venous-type channels, usually thin and fibrous, lined by flat endothelium, surrounded by smooth muscle that is often focally absent or scant relative to the channel size. So this is similar to the thin-walled vessels. However, in cavernous hemangioma, the vessels are usually more largely dilated compared to that of our patient. And thick vessels are less common. And also, in cavernous hemangioma, the lumen usually contain blood and thrombi, not seen in our case. So out of these, we can say that the findings in the deep dermis is most compatible with cirrhoid or arteriovenous hemangioma because of the presence of both thin-walled and thick-walled vessels. Based on these differentials, it appears that the findings of our patient do not fall into one specific histopathologic diagnosis, but shows a combination of findings, particularly lymphatic, thin-walled, and thick-walled vascular malformation. Hence, we are signing this out as a case of combined lymphatic and cirrhoid hemangioma. There are indeed cases of combined malformations in the current ISSBA classification of tumors and malformations, but I also found this case report of a rare case of hemangiolymphangioma, which are defined as a proliferation or network of vascular spaces or vessels of varied nature. So it can be lymphatics, venules, arteries, lined by benign endothelial lining with intervening connective tissue stroma and forming a tumor. And so in this case report, it was a combination of lymphangioma with a capillary hemangioma. So histopathologically, this can also be a consideration. So these are my references. And with this, we must keep in mind that somehow histopathology has its limitations in diagnosing vascular malformations, since what we have here is just a representation of the entire lesion of our patient. Our diagnosis should always be correlated clinically and also with the aid of our radiologic imaging, such as MRI, to further delineate the extent of the lesion. And thank you very much.
Thank you very much, Dr. Alias. Do you have any questions from the floor? Okay, again, if you have questions, just type it into the chat box and later on I'm going to read it over. Okay, it seems like there are no questions. Then Riza, you can go and continue your grand rounds presentation.
Thank you, Dr. Alice, for the report. Now we go back to our diagnosis. There seems to be disparity between the clinical and histopathologic diagnosis of the case. To support this disparity, this journal by Horkbach et al. Mentions that in the current guidelines by the International Society for the Study of Vascular Anomalies, or ISSVA, diagnostic histopathologic examination is not routinely performed in the diagnostic workup for patients with vascular malformations. In our case, although there is a disagreement in the final histopathology and the likely clinical diagnosis of the patient, we recognize that histopathology has its limitation and that vascular anomalies is a forever evolving group of malformation, and that newer discoveries are unearthed with the aid of technology-driven and less invasive imaging modalities. Our final working impression for this case is still verrucous venous malformation or verrucous hemangioma. Now let's go back to the course in the OPD. After the presentation to pediatric dermatology, patient is then referred to different departments for co-management of the case. Since we are contemplating to give medical management to our patient, specifically sirolimus, patient is then referred to the pediatric oncologist. Laboratories were reviewed and patient was cleared to start for sirolimus. Patient is also referred to TCVS and plastic surgery for possible surgical resection. The contemplated procedure is for wide excision under general anesthesia. Wide excision under general anesthesia will be done to the patient by plastic surgery. Then TCVS will scrub in to ligate the possible saphenous vein connection seen in the MRI. Then closure with rhomboid flap of the lesion. Patient is then referred to a geneticist, Dr. Eva Cutionco de la Paz, one of our reactors today, for possible gene testing of our patient. Pre-genetic counseling was done via Zoom and was cleared for genetic testing. After clearance, patient is referred to KK Women's and Children's Hospital in Singapore. Patient is enrolled in a research study entitled Comprehensive Genomic Profiling of Pediatric Brain and Solid Tumors. The purpose of the study is to look for genetic changes by doing a comprehensive genomic profiling in vascular anomalies and tumors and pediatric brain and solid tumors to identify mutations that may provide information in the diagnosis, prognosis, and the treatment of the patient. So this is a summary slide of the course in the OPD so far. Medical management was the management of choice for our patient due to the psychological and financial constraints of our patient. In the JAAD article by Zhang et al., entitled Sirolimus is a treatment for verrucous venous malformation, a retrospective cohort study. They computed in the journal the BSA multiplied to the recommended dose of 0.8 milligram per meter square. Since our patient is a pediatric case with a low weight, we started at a conservative dose of 0.5 milligram per tab once a day for now, which we slowly increase every 2 weeks. In this journal by Stenton et al., sirolimus monitoring should be done with the target trough levels of 12 to 20 microgram per liter. For our patients, since sirolimus levels were taken after 14 days of 0.5 milligram per tab once a day, while awaiting for the results. Since the results of our patients is below the target trough range, we plan to increase the dose to as we had room to increase the dose of our patients. Here are the photos from the initial consult and the latest photos of the lesion of our patient. There is noted 20 to 30% improvement in terms of the elevation and size of the lesion since the start of the treatment. Patient has had good compliance with medications and noted no side effects since the start of the taking of medication. So for my brief discussion of verrucous venous malformation, here's an outline of my brief discussion on vascular anomalies. So vascular anomalies has had issues with nomenclature that has been causing confusion and misunderstanding in the diagnosis and management of patients with vascular anomalies. Moloken and Glowacki in 1982 proposed a classification system for vascular anomalies based on clinical behavior and endothelial cell characteristics that they divided to hemangiomas and vascular malformation. This has been adopted by International Society for the Study of Vascular Anomalies, and fast forward has been recently updated in 2018. Vascular anomalies are divided into vascular tumors and vascular malformations. Vascular tumors are characterized by cellular proliferation and include congenital and infantile hemangiomas. They are characterized by significant growth during the first several months of life, followed by slow spontaneous involution over the years. On the other hand, vascular malformations are due to errors of the development of vessels that occur during the 4th and 10th weeks of intrauterine life. They grow proportionately with the patient and usually do not regress. This will be discussed further by my reactors later on. Based on the history and PA of the patient, we will now focus into vascular malformation. Verrucous venous malformation or verrucous hemangioma is a rare congenital anomaly and is classified as a subtype of venous malformation. MAP3K3 mutations are associated with this type of malformation. The incidence of venous malformation is not known. However, in a journal by Vicola et al., they assessed that the range is between 1 out of 5,000 and 1 out of 10,000 births. The lesions range in this study is from very small to extensive types of lesions. In our local data, PDS has recorded 22 cases of verrucous hemangioma and verrucous venous malformation in 2011 to 2018. In this diagnostic pathway of patients with clinically suspected vascular malformation, history and physical examination should be done initially to our patient, followed by radiological imaging such as MRI, ultrasonography, and diagnostic angiography. Diagnostic incisional biopsy can be done in atypical cases. Clinical diagnosis of vascular malformation will be based on the ISSVA classification. These are the suggested diagnostics for the patients with malformation. As mentioned, imaging studies are necessary, which includes plain radiography, Doppler ultrasound, and MRI. A step beyond our case, we can request for genetic testing for our patients with clinically suspected vascular anomalies. In the local setting, with the help of the National Institute of Health, they can guide us which ones are available in the country and which ones are for send out abroad. For our case, we are planning to send out to Singapore for testing. Managing of patients with VVM requires multidisciplinary and an individualized approach. The indications of treating patients with VVM are the following. And for our case, we are leaning towards the indication of functional impairment due to the psychological effect on the child. Management is divided to 3: medical management, procedure or surgical management, and lastly, patient education and counseling. We started the patient on medical management, which is sirolimus. Sirolimus is an mTOR inhibitor. In this journal by Stenton et al., as I mentioned, sirolimus monitoring should be done with the target trough levels of 20 12 to 20 microgram per liter. Those adjustments will be based on the trough levels after initiation of therapy or dosage change. Laser and surgical management are still the first-line treatments with BVM. Treatment options include sclerotherapy, endovenous laser therapy, venous embolization, and surgical excision. Since some of these are not available in East Avenue Medical Center, only surgical excision was a contemplated procedure for the patient, suggested by the plastic surgery and PCDS team. One drawback of surgical excision is that if not completely excised, recurrence might occur in the patient. Patient education and counseling is also important. A team of dermatologists and other healthcare professionals are necessary for the education and counseling of the patient and his family members. There are limited available reliable sources online, and it is best that we guide them towards those reliable ones. A written action plan can also be done as to provide structure to our patient care. For the future plans of my patient, close monitoring and follow-up of our patient will be done. As mentioned, sirolimus levels will be increased to 1 milligram per tab twice a day. Since the consent and assent forms are already signed by the patient and the mother, specimens are being prepared for send out to KK Women's and Children's Hospital in Singapore through the help of the National Institute of Health. Thank you. That's the end of my presentation.
All right, thank you very much, Raisa. Do we have any questions from the floor? Or if you wish to, you can just unmute and ask your question. So Raisa, where are we now in the treatment of this patient?
So, Doctora, we are already currently in the the process of submitting for genetic testing for our patient po, Doctora. So, we already enrolled the patient po through Singapore Health in KK Women's and Children's Hospital. So, currently, Doctora, we're already done with the parang Zoom call with our from our team and then from the team of Singapore regarding to the consent and assent form of our patients po.
Okay,
At the same time, for the medical management po, we are still continuing with our sirolimus medications po.
All right. So in terms of sending the specimen, would you know what type of specimen we should send to KK Women's and Children's Hospital for the genetic sequencing?
Doctora, during our Zoom call po with Singapore, they were requesting for slides po, Doctora. So since we already done biopsy po, we are planning to do a recut po of our slides po, Doctora. Pero there's no we're not gonna stain to the slides po. So we're planning to send 72 slides po to Singapore po, Doctora. And hopefully
Actually,
kasha po
72.
yung...
Yeah. Okay, sorry.
Yes po, Doctora.
We are not going to rebiopsy the patient. We're just going to use the old block, and we're going to send them 72 cuts, not 72 slides, just 12 slides with 6 cuts each slide.
Sorry, Doc.
Okay, for them to be able to, so that our specimen will be enough for the genetic sequencing. All right, so are there any other questions from the floor? Okay, so at the moment, there's none. So that concludes the part 1 of this case discussion. We are now about to go to the part 2 of our case discussion. However, although many of us now, if not most of us, is yearning to travel, our current global health situation limits our wandering. So nowadays, part of the normal or the new normal in traveling is not just to have your travel passports with you, but to have your vaccination card as passports as well. No, to satisfy that longing to wander the world, the East Avenue Medical Center Department of Dermatology invites everyone to travel again, and this will be on August 5 and 6. So please watch this video and fall in love with traveling again. After this video, we will be back with the part 2 of our case conference.
flight GA, please go to gate 26.
Mabuhay and welcome to East Derma Airlines. Ladies and gentlemen, we will be taking off shortly, so please straighten up your seat back. Make sure your seatbelt is securely fastened, window shades fully opened, tray tables towed, and get ready because we will embark on our journey in a few minutes. Maraming salamat po.
All right. Do we have the video with the speakers already looked?
Yes po, Doctora.
Okay, we can show it now. Thank you.
Thank you.
Okay, please stand by. We're just having some technical difficulties. So the next video will be showing us the topics for the day, per day, on the 2-day postgraduate course of the East Avenue Medical Center. All right, thank you very much. So see you on August 5 and 6. We are still awaiting our registration links, but as soon as we have, we're going to post it all up on our Viber groups. All right, now for the part 2 of this special pediatric lecture series, today, we are very lucky to have with us the experts in the field of clinical genetics and pediatric dermatology. This conversation with the experts will begin with the lecture of Dr. Gisela O'Malley Adasa. She graduated from the University of Santo Tomas Faculty of Medicine and Surgery, had her residency training at the Research Institute for Tropical Medicine. She had her fellowship training in pediatric dermatology at the Northwestern University Feinberg School of Medicine and Robert Lurie's Children's Hospital in Chicago. She also had a fellowship on dermoscopy under the American Academy of Dermoscopy in the University of Cincinnati in the US. Currently, Dr. Adasa is the head of the Pediatric Dermatology Unit at the Research Institute of Tropical Medicine, and she's also an active consultant at the Asian Hospital and Medical Center, San Juan de Dios Hospital, and the Medical Center in Muntinlupa. Our next and definitely an expert in the field, expert panel reactor for today is Dr. Eva Maria Cutionco de la Paz. She finished her Doctor of Medicine from the University of the Philippines, had her pediatric residency at the UPPGH. She was once a research fellow in molecular genetics at the International Center for Medical Research at the Kobe University Graduate School of Medicine in Japan. She also furthered her fellowship training in clinical genetics at the Hospital for Sick Children at the University of Toronto in Canada. Previously, she served as the Vice Chancellor for Research at the University of the Philippines, Manila, and currently, she's the Executive Director and also a Research Professor at the National Institute of Health of the University of the Philippines and a Clinical Professor at the Department of Pediatrics of the Philippine General Hospital. And the most important of all, she's the director for the Genomics Health Program of the Philippine Genome Center and is part of the IATF Technical Working Group on the variants of your SARS-CoV-19. That's why you will always see her being interviewed in CNN or any other news show on TV. So we're lucky to have Dr. Eva Maria Cutionco de la Paz with us today. And I will be your moderator. So to start off the topics for the conversation, I will have to resolve the critical issue in the diagnosing vascular malformation. As you've remembered, the histopathology was not the same with that of our clinical diagnosis. Number two, from Dr. Adasa, she will give us some pointers and advice on how to nail the diagnosis of vascular malformation. And then a very important part, probably something new to us dermatologists, the genetic counseling in vascular malformation or vascular anomalies, which will be given to us by Dr. De La Paz. And then towards the end, I'm going to show you what collaborative and multi-center approach or treatment for patients with vascular anomaly. So of course, I want to resolve the critical issue on the disparity of the clinical finding and the histopathology for this case. Well, the issue of nosology was discussed by Dr. Adasa in her lecture, the hemangioma versus the malformation. So I'll focus on the disparity. What happened? Why is the clinical and the histopath not coherent with each other? Okay, so let's remember that in dealing with vascular anomalies, the manifestation usually manifests during childhood in the pediatric age or in the pediatric population. So if you are to diagnose a child, you have to make sure that you're utilizing the least invasive technique to help you in diagnosing. Or if you cannot just do with the less invasive ones, if you really need to go into the invasive diagnostics, at least it might be curative as well. So these are your embolosclerotherapy. Now, another thing is the evolution of lesions. Dermatology or pathology books probably have had observed or had records of fully evolved lesions, but lesions that are just in stages of evolution, probably the clinician and the pathology will need a good criteria so as they can classify which one is a fully evolved lesion of verrucous hemangioma and which one is just an evoluting one, because in the pediatric population, there are a lot of factors. This patient is just a 10-year-old male. He is about to go into adolescence, and usually verrucous hemangioma or verrucous venous malformation undergoes a variety of changes, especially during surge of hormones, and this is during adolescence. And remember that in vascular anomalies, what are the organs involved? It's the blood vessels. So we don't just readily open up something that we don't know what the status of the blood vessels are. Is this just a slow flow? Is it a medium flow? Or is this a high flow type of vascular malformation? So with this, I would like to go through some journal articles that I've collected and I've read or chanced upon as I was preparing this presentation. And this vascular malformation and their unpredictable course. Congenital malformation has long been an enigma, something of a problem, a conundrum in medicine because of its wide range of clinical presentation, unpredictable course, erratic response to treatment, and the high recurrence rate and morbidity. So in this journal article, they've concluded that the newer diagnostic technology, the less invasive one, such as your MRI, has aided in the differential diagnosis of congenital vascular malformation. And this has provided a more precise diagnosis for your vascular malformation. And it's not only us dermatologists or the plastic surgeon, even our orthopedic surgeon counterparts also has problems with misdiagnosis when it comes to vascular anomalies. And in this review article, they've concluded that to correctly classify a vascular lesion, the clinical history and appropriate imaging are fundamental, and histologic examination, although advisable, has sometimes a secondary role because it is often possible to obtain it only after a lesion is completely removed or excised. Now, this journal article by Brugum utilized magnetic resonance imaging to evaluate vascular malformation of the lower extremities. And they found out that two of the most useful non-invasive techniques for assessing your vascular anomalies or malformation is MRI and ultrasound. And MRI is the best single modality for demonstrating detailed information regarding the involved structures, the extent of the lesion, and the flow characteristics of these the vascular anomalies. Another one combines magnetic resonance imaging with magnetic resonance angiography. So they found out here that MRI is really superior as an initial diagnostic test for vascular malformation. You need to add angiography if there is a questionable characteristic or flow of the lesion. So if you're not sure if this is a high flow or a slow flow lesion, then you can add up your magnetic resonance angiography. Now, a critical issue in the management of congenital malformation, a general review by Lee et al. Says that the arrival of advanced diagnostic technology, mostly of a non-invasive nature, also allows for a more accurate and safer diagnosis to be made. And this one was already shown by our presenter, Dr. Ossie, the discrepancy between clinical and histopathology diagnosis of soft tissue vascular malformation. And this says that diagnostic histopathologic examination is not routinely performed in the diagnostic workup for patients with vascular malformation, because in more than half of the patients undergoing therapeutic resection, the clinical and histopathologic diagnosis did not really correspond. So the establishment of a clear diagnostic criteria for clinicians and the pathologists is very important. Now, lastly, the nosology, okay? The classification of vascular anomalies has both reflected thinking of the times and hindered understanding and progress. So just a history. It was in 1940 when they first classified your vascular lesion into just two, hemangioma and lymphangioma. It's in the 1940s. In 1962, the first classification was out. This was done by plastic surgeons. This is by Old Thompson, Graben Smith. And this was only edited in 1982, 20 years after, by J.B. Mulliken and Glowacki. So when you go over journals, you'll always see these names, Mulliken and Glowacki, because Mulliken and Glowacki, their work was now the basis of the ISSVA, the International Society for the Study of Vascular Anomalies. So this is a very busy slide. So vascular anomalies is just subdivided into the tumors and into the vascular malformation. And then down the line, you see your hemangioma under the tumors. And you will see under the vascular malformation, here is your verrucous venous malformation. All right, now I'm gonna need to go on to my next poll question. How confident are you in ordering diagnostic procedures for your patients with suspected vascular anomalies? Can we pop out the poll now? There, okay. I'll give you 5 seconds to answer. How confident are you in ordering laboratory imaging as diagnostics for your vascular malformation? 5, 4, 3, 2, 1. Okay, let's close the poll. Let's open up. All right, so 63% at least is confident enough to order diagnostics for vascular malformation. Let's close this. Now, let's go on to the discussion of vascular malformation, some pointers and advice from a pediatric dermatologist's point of view.
Difficult pediatric derm cases to diagnose and treat. Even the classification, it's always evolving. Taking this case, for example, it used to be named Verrucous Hemangioma, and now it's classified under Verrucous venous malformation. And also, it requires a team to manage any vascular anomaly. So that would include us dermatologists, pediatrics, surgeons, radiologists, and even oncologists. So vascular birthmarks look alike in various shades of blue, pink, and red. This caused diagnostic difficulty that in the past was compounded by many terminology, as I mentioned earlier. And so your verrucous venous malformation, zooming on this, other name is called verrucous hemangioma. It is a superficial angiokeratoma-like vascular malformation composed of capillaries and veins in the dermis and upper subcutis. It is caused by a somatic mutation of the MAP3K3, which I will expound later on. So what do we know about your verrucous venous malformation? It presents in infancy and occurs primarily on the extremities in single or in groups. Second, that is early on, the lesions are non-keratotic. Usually it's soft, bluish red, but in time, that's when they become increasingly hyperkeratotic. It persists indefinitely and do not regress and are therefore similar in behavior to venous malformation. And so this is opposed to your hemangiomas, which regresses over time because it follows phases. Fourth is most are excised in a single procedure or even in stages, but usually requires a wide excision because it goes even deep into your subcutis. And since recurrence occurs when it is incompletely resected. And so first we define what is a vascular tumor and what is a vascular malformation. So the general differences between vascular tumors and malformation is in front of you. So a vascular tumor, a good example is your hemangioma. So it's proliferative, 30% visible at birth and 70% becomes apparent during the first week of life. It's more common in females. It has rapid postnatal growth followed by slow involutions because it follows phases. Endothelial cell proliferation is present, increased mast cell, no coagulation abnormality. It has high percentage respond dramatically when you give corticosteroid, which is the medication previously to treat your hemangioma. Immunopositive for biologic markers, your GLUT1, which is what you test for your hemangioma. And if I may add, it grows by cellular hyperplasia. Okay, for your vascular tumors. And now let's go into vascular malformation. It's a congenital abnormality with proportional to growth. It has no gender preference, may expand secondary to sepsis, trauma, or hormonal changes. It has normal endothelial cell turnover and normal mast cell count. They do not involute It's localized consumptive coagulopathy possible. It has a slow flow, it has also a fast flow. And so your malformation will depend on the speed or rapidness of the flow. No response to corticosteroid or anti-angiogenic agents. It's immunonegative for hemangioma biologic markers, which is your GLUT1. So the defect in your vascular malformation is in your vascular morphogenesis. So it still leaves you with the question whether your verrucous hemangioma or your verrucous venous malformation is under your vascular tumor or a vascular malformation. So this is a very good table wherein it delineates the essentials. So here are the characteristic for your vascular malformation in hemangioma. And on the right side will be that the characteristic of your verrucous hemangioma. So if you compare, your verrucous hemangioma has more similarities with your vascular malformation. So it's mostly at birth or in early childhood. It is proportional to individual's growth, appearance of hyperkeratosis and satellite lesions with time. It does not spontaneously regress, unlike your hemangiomas, and endothelial proliferation is present. It is positive for your Wills tumor 1 and positive for your GLUT1. So these are your indication for your hemangioma. I think this is the only similarity with the table for your hemangioma. But please take note that in verrucous hemangioma, this positiveness is not as great as what you would see in your hemangioma. It is negative for D240 and PROX1, which are your lymphatic vessel markers. So if you look at this, this is a case report wherein they have 2 cases of diagnosed verrucous venous malformation. And the one that they want to highlight here is the overgrowth that comes with it. So in the left bottom is a case of a 4-year-old with around 2 centimeter overgrowth in the limb. In this one, the patient was given sirolimus, oral sirolimus, and significantly, as you can see in the picture, the lesions have improved, flatter, and then the color has subsided somewhat. However, it did not do anything with the overgrowth, the discrepancy on both limbs. And another, in the right side is another case of your verrucous venous malformation. In this one, they did not give sirolimus, however, they did a surgical excision. This was accompanied by difficulty in mobility because of the involvement of the right foot. And this just highlights that overgrowth can occur with those with verrucous venous malformation. So it's a must that you would measure the length and take note of the ambulation of the patient. And so let's go to the mimickers. So this is a very good study that they did on verrucous hemangioma, a vascular anomaly frequently misdiagnosed as a lymphatic malformation. This was published in the Journal of Pediatric Dermatology. And so the aim of this study was to show specific clinical signs that allow for a clinical diagnosis of your verrucous venous malformation with no need for histological confirmation. So the method in this study was they divided it into 2. They had phase 1, which features of 8 patients with a histologically confirmed diagnosis of VVM from the year 2011 to 2012. They reviewed, this was reviewed by experienced pathologists. And so they reviewed the epidemiologic, clinical, dermoscopic, and imaging characteristic of these patients with VVM. On the phase 2, all subsequent patients who presented with a previously identified clinical characteristic were enrolled, and clinical monitoring was carried out without performing skin biopsy. So in the phase 1, the results that showed was 8 patients with 6 female and 2 males aged 4 to 37 years old with histologically confirmed VVM. So they had positive GLUT1 but negative D240 podoplanine. So if you recall my previous slide, the GLUT1 would signify your, it's a marker for your hemangioma, and your D240 podoplanine is a marker for your lymphatic vessels. So suggested diagnosis before biopsy were venolymphatic malformation, capillary malformation, and infantile hemangioma. And they noticed that in these 8 patients, they were always present at birth and would thicken and become hyperkeratotic over time. And all of them were located on the limbs or lower part of the body. There were no lymph angiectasia nor painful transient swelling. There was no spontaneous involution or post-operative complications. Local recurrence in one that they did partial excision, and the MRI showed well-delineated or infiltrating hypointense T1 and hyperintense T2 lesions with no or minimal contrast enhancement involving the epidermis, dermis, and subcutis, but never the muscle. So the significance of the MRI is that it had minimal contrast and enhancement. And in radiology, if this is the case and you're dealing with a suspected vascular malformation, this would give you more on the side of lymphatic malformation rather than a venous malformation. So on the phase 2 of the study, they did it with 18 patients, aged 0 to 18 years old. So this included 16 females and 2 males. So the suggested diagnosis of these patients were lymphatic or venolymphatic malformation, capillary malformation, capillary venous malformation, and infantile hemangioma. And like the first phase group of patients, they always present at birth, and the location would be the limbs, but a few had on the trunk. There's no lymph angiectasia or inflammatory manifestation were not reported. There were no spontaneous evolution or post-operative complication, which is somewhat the same with the phase 1 patients. But here they did a pulse dye laser in 5 patients for cosmetic reason with only partial improvement. And the MRI showed the same, that there was no or minimal contrast enhancement, which is what you see usually with lymphatic malformation. I just want to highlight these dermoscopic findings. Why? Because in this study, they said that the dermoscopic finding will help you diagnose your patient with verrucous venous malformation without even doing your biopsy. So just to give you an overview of what you should see if you're dealing with lymphatic malformation, because you know that dermoscopy is close to my heart. So for the residents out there, when you're dealing with lymphatic malformation, this should be what you see. So you have whitish lacunae surrounded by, this is the whitish lacunae, and then you have the septae, the pale septae. But of course, in dermoscopy, you always have to correlate it with the actual clinical picture of the patient, because this one is a more elevated lesion of your lymphatic malformation. But if you're dealing with a more discrete or a smaller lesion, this is what you see. Still the same. You're dealing with a lymphatic malformation here, so you still see the yellowish lacunae. It's like a web. It's somewhat flatter in how you visualize it in the picture. Okay, but here there are red areas. Okay, inside your yellowish lacunae. It's still divided by your septae, pale septae. Okay, so this is how it looks like with this clinical picture of lymphatic malformation. So when you're dealing with lymphatic malformation, you see your yellow or whitish or pale lacunae with those pale septae dividing it. It's just relative if you see your red dots inside the lacunae. How about if you're dealing with vascular malformation? So what you see is not yellow lacunae, but rather reddish lacunae. And that's because you're dealing with either venous or arteries, okay? So that is what you see. So this one, again, you correlated with your clinical picture, and this has a more elevated lesion, and that would transmit in your dermoscopy as a much more darker red lesion. And why do I emphasize that? Because if you're dealing with a vascular malformation that is more diffuse in redness and seems to be flat clinically, then you would appreciate a more linear red areas. It seems like a network going on here. So you see a diffuse dilated linear vessels and some perifollicular pale halos, this one, and linear vessels form an irregular network. Okay. So just to give you a picture of what you look for in dermoscopy for your malformation, capillary malformation, you can see your red, diffuse, linear streaks. Okay, and for your lymphatic malformation, you should see your yellow to whitish lacunae, okay, divided by your septae. And of course, for your verrucous venous malformation, you see thick areas of redness. And since it's verrucous, it's hyperkeratotic, you see a more hyperkeratotic or crusted lesion by your dermoscopy. So in this study, going back to that study, it says that the dermoscopy will help a lot in diagnosing your patient. So with your verrucous venous malformation was made of separated vascular elements with irregular shape in a linear disposition with variable thickness and keratosis. Its specific vascular pattern consists of an erythematous patch with scattered small red to violet dots was easily identified using dermoscopy. In many cases, the typical clinical presentation of your verrucous hemangioma is sufficient to establish the diagnosis, and a biopsy may not be required. So this is essentially what this paper is driving at. Okay? So when it comes to treatment, your verrucous venous malformation is generally difficult to treat, and I think that is true for the case we have currently. Currently, combined therapy with laser, which is your pulse dye laser or your ablative laser, plus and surgery, is considered the first line of therapy. Other treatment options that you would see on researches will be topical steroids, cryoablation, radiotherapy, but this one would have a variable success rate. However, nowadays, with the advent of discovering of the somatic mutation of the mitogen activated protein kinase 3 gene. So this study have shown that it is associated with the mutation of this gene, which is an upstream molecule of the mammalian target of rapamycin signaling pathway. So sirolimus is an inhibitor of mammalian target of rapamycin, has been increasingly used in the management of complicated vascular anomalies, just not your verrucous venous malformation, even with your other vascular malformation. And the results are promising. Okay, so this is from your JAAD. They did a sirolimus for treatment of verrucous venous malformation. This is a retrospective cohort study. So this involves 10 patients enrolled in the study at a big hospital in China between 2015 to 2017. This involved 5 males and 5 females with a mean age of 17 months. So if you look at the effective treatment response rate curve, sirolimus is around the 90-95%, if I'm not mistaken, effectivity. Okay. So in this paper, the initial sirolimus dose was given at 0.8 milligram per meter square and was administered twice daily. And the random serum level of sirolimus ranged from 6 to 15 nanogram per milliliter. To achieve the desired serum level, the weight and serum level were tested and further consulted with a doctor once a month. So the follow-up was once a month. All patients were maintained for the treatment course with sirolimus as the single agent. So no other modality was incorporated in the treatment for the patients included in this study. So this is a representative patient in that study. So this is the patient with VVM. And after sirolimus, this is about, I think, 6 months of sirolimus, and you see marked improvement of the lesion. Okay, but then again, the overgrowth as I mentioned in the previous slide, might not be addressed by your sirolimus. Okay, but in this patient, there was no overgrowth noticed with the affected limb. So, in conclusion, for this study is that sirolimus is a reliable targeted regimen for VVM and is effective and well tolerated. So this is another case report of a 13-year-old male. This is in Saudi Arabia. And you see that he has a severe verrucous venous malformation. And the thing about this is that they tried laser treatment with no improvement. Surgical management was not amenable to the family, and I think it's also because of the location of his malformation. But then the kid, as he was growing older, he had difficulty in mobility on the right arm, and so they tried a trial of the sirolimus at a dose of 1.6 milligram per milliliter per day, twice a day, and this was given for 3 years. And after 3 years, this is how it looked like. So the target sirolimus serum in the patient was 6 to 15 ng per ml, and they did follow up every 3 months for the first year, and succeeding follow-up were every 6 months. And so they closely monitored the patient for side effects. And the thing about here is that the long-term plan for this patient is that they would still continue the sirolimus as long as the patient is improving and that there are no side effects in the patient. Okay. So, but before I end, I think the sirolimus would be a very good treatment for a patient. But then since it's fairly new, there are very limited studies that would tell you how long would you give that to your patient. I mean, or how do you titrate it? Do you taper it? There's so many questions for giving this, and most of the studies out there are case reports like what I presented to you. And so I think over the years there will be much more cases that we can rely on in the effectivity and safety of this drug. And maybe this case can be added onto our data bank of effective treatment for varicose venous malformation. So what are my key points? Verrucous venous malformation is a vascular malformation that has vascular and hyperkeratotic components affecting mainly the extremities. It is caused by somatic mutation in the mitogen activated protein kinase 3 gene, so that's MAP3K3. It is often associated with complications, mainly bleeding, ulceration, with secondary infections and limitation of movement, as I presented in the earlier slide. And the treatment of vascular malformation is complex and requires a multidisciplinary team. Both medical and surgical interventions are often needed. So in the patient a while ago, the last case I presented, they are contemplating and have surgical resection on some areas of the boy's right arm, together with the sirolimus medication. So, but however, recurrence after surgical excision has been reported in the past, and so there is a high risk of recurrence if it's not completely excised. Currently, laser and surgical methods are still the first-line treatment option. However, sirolimus is a promising medication and should be included in the treatment option. And I think this is my last slide. Thank you for having me here. And I hope you learned something about your verrucous venous malformation.
Thank you very much, Gisela. Now, just to go over what was before and what is now in vascular anomaly treatment. Now, before, when they diagnose vascular anomalies, they rely heavily on pattern recognition. There were classification systems before, the one that I showed you in the 1940s. They just subdivided it into hemangioma and lymphangiomas. But now the classification systems are more streamlined. The ISSVA classification of 2018 is continuously updated. and they are actually comprised of several specialists doing the classification. Now, before, surgical intervention are the only treatment options. There were some medical options, but these are limited ones. However, now, in the advent of a multidisciplinary approach to the treatment of your vascular anomalies, medical therapies are slowly increasing. Now, there are phenotypes and genotypes and some biomarkers that are being discovered through clinical trials for your vascular anomalies. And with this, I will segue you now to the pharmacogenetic part of your vascular anomaly. So this is a very scary and busy slide, but I don't want you to be scared. I just want you to focus on the PIK3CA here. Let me annotate. Okay, I hope you can see my mouse now. So this PIK3CA inhibitor is actually what we are trying to sequence in this patient's genes. We are sending the patient's slides or patient's tissue to Singapore because Singapore will try to sequence PIK3CA. PIK3CA, if you can see, is actually a gene that can be mutated in various disease entities. So venous malformation is here and all other syndromes along the line. And then going down into the green one, you'll see along the pathway of the PIK3CA is the mTOR pathway. We gave this patient sirolimus, and sirolimus actually inhibits the mTOR pathway. So I would say that sirolimus is we're slowly increasing the sirolimus because we've waited for the trough levels, and somehow the patient is responding. And I think this patient could have a mutation in the PIK3CA pathway. Now, again, medical management is slowly increasing. It's due to the pharmacogenetic intervention nowadays. There are a lot of medications in the pipeline, such as alpelisib, vemurafenib, trametinib, sometinib, and pazopanib. And all of this, the basis is genetics. So with all this, let's now go on to our next poll question. Our poll question is, how confident are you in terms of talking about genetic testing to your patients? Let's pop out our poll. Okay, I'll give you 5 seconds to answer. How confident are you in terms of talking about genetic testing to your patients? Let's see, 4, 3, 2, 1. Let's now close the poll. Can you put it up? I would probably be answering 1 or 0 too. I'm not that confident in talking about genetic testing, nor do I have any experience in doing pre-genetic counseling, but I was lucky enough that this incredible and very accomplished physician, Dr. De La Paz, is with us today. She is, of course, a physician, a pediatrician, a clinical geneticist, and now she leads the Philippine Genome Center in sequencing the various variants of SARS-CoV-19. We are so lucky that she made time for us today. Ladies and gentlemen, please help me in welcoming into the virtual stage Dr. Eva Maria C. Cutiunco de la Paz.
Thank you, Dr. Walin Sundin, for your kind introduction. Thank you so much. I've learned a lot in the last hour and a half, listening to the case and all the histopathologic findings from you, Dr. Wilsey, and from our dermatologist, Dr.
Adasa.
Yes. And
thank you very much, Dr.
I'm fascinated with this case, but my role is to talk about genetic counseling. And I'd like to thank also Dr. Riza Ossie, who actually was very persistent in connecting with me. And so we found time on a Sunday afternoon to do counseling on this, to do genetic counseling on this patient. The patient was with her mom, with his mom. So thank you again for inviting me. And just some words about genetic counseling. It's really a communication process which aims to help individuals and families understand and adapt to the medical, psychological, familial, and reproductive implications of the genetic contribution to specific health conditions.
Doctora, you're on mute, Doctora.
Have I been on mute like from the beginning?
No, just this slide, Doctora.
Okay, sorry. So just to repeat, the process actually of genetic counseling involves interpreting family and medical histories to assess the chance of disease occurrence or recurrence, educating the family about the natural history of the condition, inheritance pattern, testing, management, prevention, even support resources and research. Counseling them to promote informed choices in view of risk assessment, family goals, ethical and religious values, and also providing support to encourage the best possible adjustment to the disorder in an affected family member and or to the risk of recurrence of that disorder. Genetic information is complex and can really be daunting and needs to be presented in a meaningful and open-minded way that is relevant to the individual needs of each patient to facilitate informed decision-making. At the end of a pre-genetic testing counseling, the patient or the family may opt to have testing done as a form of empowerment, but we also consider the families who may not opt to do genetic testing because sometimes what they don't know won't hurt them. So ignorance is bliss. So these are all the issues that are included in the counseling session. So the diagnosis and information discussed in genetic counseling frequently has implications for other family members. So let me just walk you through this slide. This is the process that we went through that Sunday afternoon 2 weeks ago. So the patient, the patient was referred to for a genetics consultation. The first is this pre-genetic testing counseling where we do the medical history. A big part of the risk assessment is really looking at the family history. Should the patient opt for genetic testing, then we arrange that to be done. Either if the test is available in the Philippines, we do that here. If not, we arrange for the send out of samples. I do this weekly, but we do that on a Monday or Tuesday so that in a commercial testing lab in the US, it arrives there on a Thursday or Friday, and it doesn't have to be caught in customs during the weekend. So after the testing is done, post-genetic testing counseling is provided where the test results are disclosed. And should the test be informative, that means a mutation is found in the gene that is being queried, then testing of at-risk family members for early detection and prevention can also be provided. But for this particular patient, I think the test result interpretation will be very important in the treatment strategies. Now, there's another way of testing. The one that I showed you is using peripheral blood or saliva, and that's for germline mutation testing. The other one is tissue profiling for targeted therapy. We do this a lot in cancer, but it can be done for other Mendelian disorders. So again, the patients undergo genetic counseling for risk assessment. But apart from doing the usual histopathologic examinations, tissue profiling can be done. We're just about to start our clinical sequencing services at the Genome Center. And with the results of the profiling, test result interpretation can be done by a multidisciplinary care team so that the treatment can be more personalized for the patient. And you can see here that a big part of it is really also biobanking and research, so that in the near future, we can develop our own companion diagnostic test kits for our population. So what these are practically the slides I used during the counseling. I just revised a couple for clarity, but these are the slides that I used during the counseling session, which was done in the presence of Dr. Walin Sundin, as well as Dr. Ossie, and of course the family. This is a very complicated pathway, but just to show that this complex genetic pathways implicated in vascular anomalies. And the majority of identified mutations in vascular anomalies occur within two key intracellular signaling pathways. This is your PI3K, AKT, mTOR signaling pathway, as well as the RAS MAPK signaling pathway. The two are different in the sense that this pathway is crucial for many cellular processes, including cell cycle regulation, proliferation, and migration, and is often termed as the anti-apoptosis pathway, while the RAS MAPK signaling pathway also plays a crucial role for cell cycle regulation, proliferation, and migration, but it's more commonly referred to as the proliferation pathway. And in red are the disorders that our excellent speakers before me have discussed already. So I guess the challenge for us geneticists when we do genetic counseling is how to translate this into something that can be understood by the family. In this case, the patient is just 6 years old, so that may be difficult, but we try our best to communicate this information to the parent, in this case, his mom. So again, this has been discussed very well. Dr. Ablasa talked about the somatic activating mutation that may increase RAS MAPK signaling for Verrucous vascular malformation, and the gene involved is the MAP3K3. But we also heard Dr. Wilsey talk about testing for the PIK3K mutation, because these are also mutations in these genes are also involved in many of these vascular malformations. So I tried to get a cartoon diagram of the cell signaling pathway just to illustrate to the mom how each cell, how this happens in every cell in our body, where the cell membranes have a receptor that picks up signals, and there's a relay of molecular signals that happens inside the cells, and this what this does is it activates effector the transcription factors in particular, so such that the cellular response will be a gene transcription and followed by translation of the protein. Of course, we have to translate this in Tagalog, and sometimes it can really be very frustrating because it's difficult to translate English terms into Tagalog terms. But nonetheless, for the purpose of our discussion, for the MAPK pathway, it's important that signaling pathway is important in relaying, amplifying, and integrating signals from a diverse range of stimuli to elicit an appropriate physiological response, including what I've mentioned earlier, the cellular proliferation, differentiation, development, inflammatory response, and apoptosis in mammalian cells, which leads to the appearance of the lesion. Two important points that were important during the discussion is really sorting out somatic mutations versus germline mutations. Somatic mutations they occur in non-germline tissues, and they are not inherited, and mutations happen in the tissue only, while germline mutations are present in the egg or sperm and therefore are heritable. So that mutation can be inherited by an affected offspring. In this case, in many cases, they are usually inherited in an autosomal dominant manner. I use this to illustrate the somatic mutations versus germline mutations to differentiate the two. Wherein, if it's a germline mutation, the patient actually is born with one copy of the gene with the mutation, and therefore the cells are already, the cells of the individual are already predisposed or have a high susceptibility to have the genetic condition. Something happens, it can be exposure to an environmental factor that causes, or some unknown factors yet, that causes a mutation in the other gene to happen. And when that occurs on the cellular level, there is loss of proper growth control, leading to the lesions that we see in patients. So if you see here, it's a shorter time to develop because the person is already born with one copy of the gene harboring the mutation. And in these cases, as I said, and this happens usually in an autosomal dominant manner, wherein one parent has one gene that is not working well and can pass it on to his offspring, in this case of an affected father, in 1 in 2 chance or 50% for each pregnancy. So you can see here, out of the proportion of offspring, you see 2 out of 1, 2, 3, 4, or 1/2 or 50% can inherit the mutation. So how do we figure out whether this is something that is inherited through the germline? One of the more important tasks that we do during the genetic consultation is to actually do a pedigree. And this is the pedigree of the patient that I was able to get during that time. You can see that this is the patient, the proband with an arrow here, because he is the affected and the first person to come to medical attention. His square is shaded, fully shaded, to illustrate that he is the affected proband. He has 4 other siblings, 3 sisters and 1 brother, and mom and his parents had 1 miscarriage. So when I describe his pedigree, it will be, he is the youngest in a sibship of 5, born to non-consanguineous parents. The dad who died just recently died at the age of 41, and if I remember correctly, it appeared to be a cardiovascular disease. And so this is a 3-generation family pedigree. You see where they come from as well. And there are no other relevant or pertinent findings in this family history. There are no known cases of vascular malformation. So that is for an inherited type, but many of the cases are also sporadic, especially for verrucous vascular malformation. And the way we discuss it is in this manner. This the patient is born with 2 normal copies of the gene, therefore he has all normal cells. But then 1 copy of the gene acquires a mutation de novo, and the cell remains normal. However, once the other other copy of the gene acquires a mutation due to some environmental factor or yet unknown factors, then the 2 copies of the gene now have a mutation, and therefore this starts the loss of proper growth control and abnormal growth happens on the lesion that we're able to observe in patients with VVM. What is recommended for this particular case is to do somatic genetic testing. And as has been described by Dr. Wilsey and Dr. Riza, the samples that have already been collected previously, they will have the cuts sent to KK Hospital, where human fibroblasts will be established, and then they will extract DNA for genetic testing. Sometimes they can skip this and just go directly to extracting the DNA from the tissue and doing the genetic test. In the beginning, we used to do a single gene test, but for most of my patients now, I recommend multi-gene panel testing so we don't have to go back and forth. If in this case, Dr. Riza described a panel for pediatric brain and solid tumors, which will pick up the common genes that are involved in cell proliferation and differentiation. So during the counseling session, I had to talk about the chromosomes, that we are made up of many cells, and each of our cells contain a set of genetic material called chromosomes. If you stretch out these chromosomes, it's a long stretch of DNA. And in the DNA, you will find 20,000 genes, which are coded messages that will dictate how we will look, whether we're going to be tall or short, dark or fair, color of our eyes, the blood type, and even genes that are important in those cell cycle. So those genes code for proteins that are important in the cell cycle regulation. I also have to discuss with them during the genetic counseling session that this genetic code, they're like sentences. The genes are like sentences in a chapter in a book. For example, you have the word red. If there is a single misspelling of the word from E becomes a T, then RDD is not anymore equivalent to red. Or sometimes it's a disruption in a sentence. Here, the car was red. The car got deleted. The was red does not make any sense. So these mutations are like misspelled words, or the disruptions of the sentence in a genetic code will now make the protein that's produced not functional anymore. And then the last part of the discussion will really be the results of the genetic test, because genetic tests are not straightforward in interpretation. Sometimes they are, but sometimes they're not. So the results can be a positive result, a negative result, or a variant of uncertain significance. When it's a positive result, this means a significant genetic change in one or more genes tested has been detected, and they're pathogenic variants, they're known to cause disease. If it's a negative result, means no significant genetic change has been demonstrated in the sequencing, and that means no pathogenic variant was detected. But always we discuss the limitation of genetic tests, that sometimes the test assay may not be able to detect all mutations. Of course, right now, I think that's a smaller probability compared to many years ago when I started practicing genetics. But still, that limitation exists. And the last one is the result of a variant of uncertain significance, which means that no significant change pertaining to a pathogenic variant or mutation has been detected. However, the sequencing was able to pick up a genetic change, but it has not been found to have any impact on health. It is still uncertain at the moment. So these families get enrolled in a program called VUS family program, because at some point in time, when they're able to demonstrate that this is indeed a pathogenic variant, they'll contact the family and the physician, or sometimes they will be able to resolve that it's just a polymorphism, which is a change that is greater than 1% of the population. So that may not have a significant clinical impact. And so those are the things that we discuss. I hope that the key message that I just want to convey to you is that for any genetic test, pre-genetic testing counseling as well as post-genetic testing counseling are integral to the process, because there's a lot of genetic education that happens. We even explore motivations for testing and the impact of a negative and a positive result to the patient as well as to other at-risk family members. So that's it. Thank you for your time listening to this presentation.
Thank you, Doctora. We truly appreciate the time you've given us today. So I'm just going to wrap up this discussion before we go on to the open forum. So eventually, it is likely that it will be possible to sequence a patient's genome and identify not only the genetic disease, but also the predisposition to complex multifactorial disease, best treatment option for the individual, and the prediction as to how they may respond to specific pharmacogenetic intervention. This phenomenon will affect every area of medicine, and dermatologists have the opportunity to be at the forefront of this new era. Now, this is very important, the multidisciplinary approach, because this has enabled diagnostic accuracy and improved management of patients with congenital vascular malformation. This is through the full integration of various surgical, non-surgical, and medical therapies. So a pediatrician, a dermatologist, a pediatric dermatologist, a clinical geneticist, a hemato-oncologist, interventional radiologist, our surgery friends, a pathologist, and dermatopathologist all play pivotal roles in the holistic treatment of our patients with vascular malformation. Their collaborative effort will bring about better patient outcome and will definitely lead to better quality of life to our patients. And this will translate to better healthcare system, a healthcare system that is not sick care, but really healthcare. Okay, so with this, we end our case discussion. We are now ready for your questions. Okay, there's one question in the chat box. In cases such as this, which subspecialty department should we best refer to initially for diagnosis and management? There seems to be an overlap among multiple specialties. So in the interest of streamlined treatment, to whom should we best refer similar cases? So as I've said, as dermatologists, we are in the forefront of treatment of vascular malformation. So hopefully after listening to this lecture, you are empowered enough to somehow look and diagnose your patient, order the laboratories, and when finally you've ordered your laboratories, you can probably refer them to pediatric dermatologist or the surgery people, either orthopedic surgeon if it's on critical bony areas, or in critically cosmetic areas, you can also refer to the plastic surgeon. Now, who gives the sirolimus? I dose the sirolimus of this patient because I've had training under the supervision of hema-oncologists during my training. But yes, a hema-onco is also necessary. Clearance from them is also important because this is sirolimus. Okay, so I hope I answered your question, Vanessa. Aruni, you're raising your hand. Yes.
Hi, Rosie. Good afternoon. My question is for Dr. De La Paz. Hi, Doctora. Good afternoon. Thank you so much for sharing your expertise with us today. My question, Doc, is in case in the future we also see similar cases such as this, would you always advise for us to do genetic testing, or can we just go ahead and do our interventions?
Thank you, Aruni, for your question. I emphasize this when it's not like for this, it's a dermatologic case. So if it's a dermatologic case, neurologic case, our role for genetics is really to provide the genetic, to provide the pre-genetic as well as post-genetic testing counseling, as well as facilitate the testing that actually happens. I think what is important for us to determine is if the testing, if knowing the genetic mutation is important in the management. In our country where the genetic testing is not readily available yet, but we're trying our best to hopefully solve that soon. I think it's important for us to determine why do we want to do the genetic test? Is it something that will help in the treatment, or is it something that the family wants because it's important for their reproductive risk, reproductive decision making? So we explore those types of motivations for testing. In this case, I believe it's because it can change the management. And in many of the cancer patients that I do counseling on, it's because there is a specific, knowing the mutation helps in targeted treatment. I hope I was able to answer your question, Dr. Aruni.
Yes, Doctora. Thank you so much.
Thank you, Aruni. Yeah, genetic testing not only tests the disease, but also it can be an aid in a specific pharmacogenetic intervention in the future. Thank you. Lyra, you're raising your hand.
Hi, Wales.
Hi, Lyra.
Well, before I ask my question, actually, it's just a practical question. I would like to thank our speakers for this afternoon. We really learned a lot from their lectures. So, actually, the question is about sirolimus because it's quite new to me. I'm not really familiar with the medication. So, one question is, but when you give it, what are the safety precautions that we need to watch out for? Where do we usually get it? Is it from only available from the big hospitals, or do we have to make a special order to have the sirolimus medication for our patients?
All right. Thank you. I think our Grand Rounds presenter, Dr. Riza Ossi, can answer that question. Riza?
Hi, Doctora. So for our sirolimus medication po, we were able to get the medication from initially PCMC, and then apparently it's also available po in some Mercury drugstores po, Doctora. For sirolimus testing po, we have to look out for a lot of side effects such as GI symptoms. We also check for the labs of our patients. So we had to do CBC every 2 weeks, and also lipid profile for our patient, because we also look for watch out for hypertriglyceridemia and also hypercholesterolemia, Doctora. So actually, sirolimus is kind of expensive po, Doctora. So sirolimus is, for the 0.5 milligram per tab, it's around 208 pesos. And then for the sirolimus 1 milligram per tab, it's around 270 pesos. Those are the two available doses po in our country po.
Thank you very much. Yes, that's correct. Lyra, mostly the sirolimus has very GI symptoms. Sometimes it resembles the chemotherapy-like side effects, nausea, vomiting. And sometimes we dose your sirolimus together with the cyclosporin. So we have to watch out for blood pressure as well, even if these are pediatric population. Thank you very much.
Thank you very
Doctora,
much.
Thank you, Lyra. Thank you very much. Dr. De La Paz, there's one more question in the chat box from Dr. Mariel Villanueva. She says, thank you very much, Dr. for the lecture. May I know if in the genetic counseling in the Philippines, there has been cases where families opted not to have other children because they had a child with a genetic disease condition?
Thank you, Doctora, for your question. Yes, actually, not this in particular, but for certain Mendelian disorders, there are families who may opt not to have another child, especially if it's it's looking at risk. For example, for autosomal recessive conditions, it's a 25% chance that it will happen again in a pregnancy. Autosomal dominant, if one parent is affected, it's a 50% chance, or 1 in 2. So it depends on how the families take this risk. There are newer ways now, although you all know that prenatal testing or prenatal diagnosis is not allowed. I mean, it's practiced in the Philippines, but because termination is not an option because of our law, we have not really done regular prenatal diagnosis in the Philippines. So other families sometimes opt to go out of the country to do amniocentesis or chorionic villi sampling. But now in the Philippines, we have what we call a non-invasive test called non-invasive prenatal test. So it's just using maternal blood, and they can be tested for trisomies, common trisomies like trisomy 21, 18, 13. For specific disorders of a single gene, like Mendelian disorders, we still do tests. I mean, if they want to do pre-implantation genetic diagnosis, it will have to be done outside of the country. Now, having said that, I think they're starting that in St. Luke's Medical Center, BPC. But most of the patients before they go out of the country for such procedures.
Interesting. Now it's available. Okay, thank you, Dr. Now, a question from Dr. Prieto. What now is the more appropriate term? Is it verrucous venous malformation or verrucous hemangioma? So as was explained by Dr. Adase, the reason it was named as a hemangioma is because of the positivity to the immunostain GLUT1 and the WT1. But when you compare the intensity of the staining, the verrucous venous malformation has very low intensity of staining. That's why the real proper and appropriate term technically is verrucous venous malformation. Thank you, Dr. Prieto, for that question. So any other questions? Right, so there seem to be no more question in the chat box. There are no participants raising their hands. Okay. So thank you, Dr. De La Paz, for the time. I'm still fangirling when I see you in CNN. So I'm really, really thankful that you're here with us today. Thank you very much, Dr. Ozzy, for helping us and inviting Dr. Putyungco De La Paz.
Thank you. Thank you. I actually learned a lot more than you know. I enjoyed my listening to all the case and all the speakers and the questions. Maraming salamat din po.
Thank you, Dr. So with that, we end our two-part special pediatric dermatology lecture series. Thank you very much, everyone. We hope to see you again in 2 weeks for our next Grand Rounds presentation. Thank you. Congratulations, Riza, for a very good Grand Rounds presentation.
Congratulations, Dr. Ossie, and thank you.
Thank you.
Riza, we can show the video of the post-grad. Good afternoon. Dr. Lovadia, do we have any announcements po prior to
We will just have a brief meeting with the consultants when everybody has exited.
Thank you, Dr. Thank you po.
Thank you. So good afternoon. Congratulations to the whole team. Another afternoon of learning, and I wish you all the best. Congratulations.
Thank you, Doktora. Thank you po sa tulong niyo pong lahat.
Yeah, so, okay, thank you. So, so the consultants will please stay for a while. I think we're good to go. Yeah. There have been, I just want to update you, there are some new developments in our department, no? And one of which is that we are finally acquiring. Oh, okay, maybe we should disconnect ourselves from YouTube.